Now in standing position, the person can stand in a walk standing position, or in a stride standing with both legs apart, wide apart, and lean on the table with weight bearing over the hands. Then gradually shift the weight forward, backward, and side to side. This increases approximation of the joints of hand and provide activities of extensors of hand, upper limb, as well as the stabilization of the scapular region. In prone kneeling or crawling position, weight bearing can be done on one or both the hands, and weight shifts can be done in all the direction. The person can be taught to lift and place one hand to improve weight bearing on the other hand. This includes activities of muscle group of the upper limb and scapula, as well as the activity of muscles of the trunk, pelvis, and lower limb. So, as a whole, these activities can train balance and coordination for a person. Another example is when the person is standing with his one hand supported on table or back of the chair, and he starts walking backwards while maintaining this position, gradually comes down, bending his knees, partially squatting, and this will cause flexion or elevation of the shoulder joint. This can be used as an assisted range of motion exercise for the shoulder joint. Now, during this whole topic of functional re-education, as we know, we have focused on the functional activities to make the patient independent out of the bed and functional as soon as possible. Summary of this functional re-education can be given in 5 clinical learning point of views. First, we use normal developmental sequence because we want to train normal functional activities, normal muscle activation sequences, and normal activity patterns. Second, we use principles of stability by manipulating the base of support and center of gravity and limits of stability in each position in each activity. Third is we have to prioritize early mobility in the bed and early ambulation outside the bed and into the community. Next is we have to aim for functional outcomes and not just the range of motion or strength. We have to decide the patient's optimal functional level, what he can achieve on the basis of evaluation of the patient. And last but most important is we have to design the protocols which are goal oriented, and we should not just stick to the theoretical protocols which are given in the book. We have to work according to the patient's need and patient's goal which are functional. That is why we are working on the functional re-education of the patient. We will be starting the practicals. I will be sending you videos in the next session. I hope everybody is clear with the concepts of functional re-education. If anybody has any queries, you can contact me. Thank you. Have a great learning.